Ladies and gentlemen, thank you. I want you to put your imaginative hats on. I think EBC has taught the world community on how to approach bifurcations and put two cylindrical stents, which are not originally intended for bifurcations, at bifurcations where there are different angles, different sizes, and we've worked at it in such details and educated the whole community. We have learned from that, and I think we have an innovative, relatively simple way of doing it. We've shown it here a couple of times. We are fortunate now to submit for our pivotal trial application next week for an IDE. Just before doing that, we had 6 consecutive implants about 2 weeks ago, which I'm going to show you. We've turned something which is tedious and hard to do with many pitfalls into something which is relatively simple. Of course, we have to show you and we have to generate the data. We're just beginning to do so. So I'm going to show you some of the things we've done. I'm going to quickly remind you of how it works. So what if we could simply stent bifurcations seamlessly, the way we do non-bifurcations, leaving a symmetrical scaffold behind that molds the bifurcation anatomy, extending into the corona, side branch ostium, without any deformity or malapposition. And that's our intention. So we have a delivery and stent integration system, which is 6 French. It's a very low profile 6 French. The catheter combination is significantly lower than 2 catheters that we put in now. Our crossing profile is 060, and our highest profile is 065, which simplifies the technical decision-making aspects of bifurcation stenting. It's designed to mitigate many of the pitfalls of the current bifurcation stenting techniques and lead to symmetrical deployment of a stent at the bifurcation with protrusion into the ostium side branch without any deformity. It enables stenting of all bifurcations in a simple, reproducible procedure. That's our intention, and guaranteed side branch access. We call our system a Provisional Plus. It's provisional, but not exactly the provisional we do now, where we have to rewire into the side branch. By definition, by design, we flare into the ostium of the side branch. There is no rewiring required. There is no deformity when we're done. There's no malapposition as a consequence. Of course, we'll show you that. And in majority of cases, if you need a second stent, it's a simple T-stent, maybe a tiny protrusion, but if placed properly, not much more. We're going to attempt to show you that. I'm going to quickly remind you of how it works. Here's an animation. It's a dual catheter system. It's important to remember it's the dual catheters are not fixed. The daughter catheter and the mother catheter are independently movable. They rotate independently and they move independently also. What you don't see in the animation here is that there's a sleeve on the mother catheter where the daughter catheter is threaded before it's threaded through the proximal part of the stent. We go to you pre-dilate, get your lesion ready, go to the corona, pull back a couple of millimeters, pull the side branch balloon and put the 2 radiographic markers together, go back to the corona. Here's what we do, which is different. We inflate the side branch balloon first. In that process, if you need a phase shift and the wire bias is as such that the stent would not look down the barrel of side branch, the balloon inflation takes care of it. So the proximal part of the stent is looking down the barrel of the side branch. We inflate the main branch balloon and then we kiss. Actually, what we do now, we inflate the side branch balloon first. We don't even deflate it. We inflate the main branch balloon and then we deflate both. We've made certain arrangements, again, to take care of the shortcomings we have now. Our 3.0 stents go all the way to 5.5 proximally, and our 3.5 stents go all the way to 6. The issue of wire wrap has been an issue in the past. So I'm showing you in a very classic, in a clear tube. You saw there were multiple wire wraps. The system does turn around the wire wraps and mitigates it. We go back, we pull back. It's very hard to see with naked eye, but radiographically, obviously, you see the markers. We pull back the side branch balloon. We put the 2 proximal markers together. Again, it's hard to see the whole depth in focus. So we go back to the corona. As we go back inside the bifurcation, it's easy to see that the aperture is not exactly in front of the side branch. So I want you to pay attention to what happens as we deploy it. As we inflate the side branch balloon, the stent rotates, if necessary, in the proximal segment, looks down the barrel of side branch. We try to show it in slow motion. The other thing which is very important is look at the proximal part of the stent. The stent is deployed into the side branch. Not only it flares, and it's perpendicular to the axis of the side branch. So a second cylindrical stent, if you put right next to it, would be deployed perfectly without having a gap. And you don't need to overlap. We deflate the balloon and we remove the system and pot. From the corona to the proximal segment is about 8 millimeters. So by doing so, we're turning something which is in the decision-making very difficult into a relatively easy decision-making. We're taking the anxieties of rewiring away, and we're taking a lot of the issues we have now away, and at the end, it's a relative simple teeth procedure if needs to be done. So this was done in Paraguay a couple of weeks ago. This is an LAD diagonal. I'm showing you, we didn't necessarily do it in this sequence, so I'm showing you the simple, easy ones. We did 6 cases in a day and a half. They were short procedures with limited resources. Unfortunately, we did not have IVUS or OCT, but we'll have it on the next trip. So Medina 111, we inflate the side branch balloon, we inflate the main branch balloon. You see how they're next to each other and without having wrapped. If you look closely, there's a tiny flare into the side branch. And I think that's one important aspect of our technology. Here is the Medina 111 circ OM. Most of us don't enjoy rewiring the OM after stenting the main branch. Here it is after predilatation. And I just want to show you, this is done under cine, just to show you the delivery of the system. We're getting radiated while we're recording this, so we can show it. It's not under fluoro. So we're advancing it to the bifurcation, and at the bifurcation, we then slowly pull back the side branch balloon. It's easier under X-ray. You see the 2 proximal markers. And when the 2 proximal markers come together, we inflate the side branch balloon. Side branch balloon first, main branch, and then B-pot. I can't go faster. It'll crash if I go fast. Okay. And look at the smooth transition into the OM. It's because it flares. Here's in a different angle. And again, this from the time we had pre-dilated, by the time we were done with the final kissing balloon, was about 5 minutes after we prepped the lesion. So here's a pretty ugly LAD diagonal. Let's see if that plays. This is after we've stented the LAD, and that diagonal is not small. Diagonal does need a stent now, and there is a flare you'll see in the next image, and we would T-stent it. See how easily the stent goes without getting hung after we've removed the balloon, and we're injecting contrast so you see the location. Here's an LAO cranial, and this is in the sequence that I showed you. Again, a pretty rapid procedure. So this patient has a left dominant system, is a very high-risk patient. It's got left main disease, significant proximal LAD disease, and a tight LAD and diagonal. That diagonal is very large, and actually with the post-stenotic dilatation, the diagonal is a little larger than the LAD. And in this case, we did do the LAD diagonal first, and we did the left main also with this device. And the way, because the diagonals appeared larger, we're actually considering the diagonal as the mother vessel, if you will. So the balloon is going into the LAD. I'll show it to you. Again, in the LAO cranial, you see how tight the diagonal is. Okay, this is after predilatation. Again, the stent is going from the proximal LAD into the diagonal. And then once we've cleared the corona, we pull back the side branch balloon, and we go back to the corona. Inflate the side branch balloon first, main branch. Now, the LAD needs a stent. We're not going to leave the LAD like that. So now we got a 3.0 stent for the LAD. You'll see, again, the smooth transition. This is as high a magnification as we could get. And again, is a relative T. Look at the right panel. And we inject contrast so you can actually see there's still flow in the diagonal. Okay, and here's what it looks like in the iliocranial. And iliocranial for the LAD diagonals tends to show all of the flaws. Now then we had the left main. I'm not going to show you all the details. We're going to run out of time. This is after we had done the left main. 2 devices in 1 patient, slightly off protocol. Okay. This is just a, okay. We may have to restart for the last couple of slides because it's not going to show it. And then we did the left main. Of course, these procedures were all very fast. I don't think it's going to run unless you restart it. Very fast, and is as simple as I showed you. This system has such a low profile, and not being fixed is that it mitigates most of the wire wrap. And definitely in a 6 French system, most people use a 7 French for the left main. If it's a 7 French, it definitely turns around and mitigates it. We've done our first few patients just before we start our pivotal trial. We are literally submitting our application next week to the FDA. In conjunction with the FDA, we will nestle a CE mark into it, and we'll be coming to some of our colleagues here for the trial, and we're delighted to be here, and thank you for giving us the time. Oh, here we go. Let's see. I think if you go back one, that would be great. Can you go back? Go back one more. One more. One more. Okay. I'm going to see if it plays. So LF main, it's probably a 50, 60%. It's not very, very tight. Again, after predilatation, we're at the corona. We pull back the side branch balloon. You see the 2 markers are there. Side branch balloon first, main branch balloon next. And final angio, we're trying to show it in as high a mag as possible. And we left the circumflex alone. And that's it, a quick procedure. Thank you very much.
Thank you very much, Mehran, and thank you for showing us. And we are looking very much forward to see you next year and see some of the initial results from when the trial starts.
Thank you. Looking
Excellent.
forward.
Thank you.